At ASH this year, we presented results from a phase 2 trial testing the combination of Rituximab and Epcoritamab for patients with newly diagnosed high-tumor-burden follicular lymphoma. So most patients for standard of care would receive chemoimmunotherapy, but CD3, CD20 bispecific antibodies are challenging the role of chemotherapy in this setting and could delay or obviate the need for chemo for some patients. So Epcoritamab is a CD3, CD20 bispecific antibody that's associated with high response rates, is already approved for relapsed or refractory follicular lymphoma. In this study, we hypothesized that 4 weekly doses of Rituximab pretreatment before the first full dose of Epcoritamab could both lower the risk of cytokine release syndrome and also deepen responses based on the distinct mechanisms by which these two drugs target CD20. Therapy in this study was time limited, given over about 9 months. So we enrolled 35 patients. They generally had high-risk features, including about 60% of patients with a high-risk FLIPI score. We observed very high response rates with a best overall response rate of 97% and a best complete metabolic response rate of 94%, both of which are high in this setting. Follow-up is still somewhat limited. Median follow-up is 12.5 months, but we've observed no relapses in patients who had a response, and the 1-year progression-free survival is 97%. This regimen was generally tolerable. CRS was observed in 46% of patients, but almost all of it was grade 1. We saw grade 2 CRS in just 2 patients, or 6%, and no grade 3 or higher CRS, suggesting that Rituximab pretreatment likely does lower the risk of cytokine release syndrome in this setting. Infections were seen in about 60% of patients, but were generally low grade. There were 5 patients who had a grade 3 or higher infection. All of those infections resolved, and patients were able to restart and complete therapy. So this regimen is very active, and I think suggests that some patients, perhaps many patients, can have excellent results without chemotherapy or lenalidomide. Longer follow-up is, of course, needed to prove that. But based on these encouraging results, we're currently enrolling a 65-patient expansion cohort to use this same combination, but with 2 small changes aimed at improving tolerance and convenience for patients. The first is decreasing the frequency of Epcoritamab dosing during cycles 4 through 9, and the second is decreasing the steroid burden during Epcoritamab dose ramp-up. So we hope to have results from the expansion cohort to present to you soon.